My dear student, good morning. Today I like to highlight one of the most important topics is called congenital hypothyroidism. It's very much important in our clinical practice. So congenital hypothyroidism. Hypothyroidism is two types. One is congenital hypothyroidism, another one is juvenile hypothyroidism. Congenital hypothyroidism occur at birth, but juvenile hypothyroidism occur children and adolescent and adult people. Remember this. Now you have to know, I like to discuss about the congenital hypothyroidism. First of all, you should know what the cause of the congenital hypothyroidism. First of all, you should know congenital hypothyroidism. It is due to congenital absence or dysgenesis of the thyroid gland. Number two is defective biosynthesis of the thyroid hormone. Then transplacental injection of metallogoitrogen, that is anti-thyroid drugs or goitrogenic diet. Next, maternal iodine deficiency. This is the causes of the congenital hypothyroidism. Remember this. First of all, you should know how to thyroid hormone is synthesized in our body. You should know the physiology of the how to thyroid hormone is synthesized in our body. You should know. First of all, you should know there is defect. Why there is a thyroid hormone dyshomogenesis? Why there is thyroid defective in thyroid hormone defective synthesis? Due to the defective in iodide form. First of all, defective in iodide form and defective in oxidation of the iodide to iodine. Number three, defective in organification, that is formation of TID, MID within the thyroid globulin. Next one is defective in that oxidative coupling of the DIT, MIT. If you remember, one molecule of DIT and one molecule of MIT form triiodothyronine. Then one molecule DIT, another molecule of DIT form the triiodothyronine, that is thyroxine. Remember this. You should remember this. This is the etiology of the congenital hypothyroidism. Remember this. Next, you should know how the patient is present at birth. How the patient is present at birth. First of all, you look the appearance. You look the appearance of the baby. You look the appearance of the baby. The core spaces. Wide often anterior and posterior portally, and wrinkling of the forehead with low hairline. Remember this. There is undue prolongation of the physiological jaundice and delayed mucinum passing and constipation. Remember this. Large protruded tongue, which interferes with the feeding and respiration. There is a noisy respiration. Remember this. And there is also abdominal distension, distended with umbilical hernia, and cold, mottling and dry skin, the hypotonia, and shortness of the neck due to excessive fat deposit over the clavicle, shortness of neck. Remember this. Next, the edema of the extremities and genitalia. Remember this. These are the findings of the congenital hypothyroidism. Now you should go for how we diagnose the case. It is completely clinical diagnosis. Remember this. Disease is completely clinical diagnosis, but we did some laboratory investigation for confirmation of the diagnosis and DD exclusion. Remember this one. First of all, we clinical assessment. Next, we go for assessment of the thyroid T3, T4 and TSS. But here T3, T4 will be reduced and TSS will be rise. Remember this one. This is the primary hypothyroidism. But when T3, T4 and TSS both are in below, both are in reduced, then you are thinking this is the secondary hypothyroidism. Remember this. Next, go for skeletal assessment of the skeletal age. Assessment of the skeletal age, that is extra of the both knee joint to see the lower femoral and upper tibial epiphysis will be absent. This is the radiological findings. Next, thyroid gland imaging. What to do? We do for ultrasonography of the thyroid gland and radioactive iodine uptake should be measured. These are the investigation. Remember this. Now what is the management? What is the management? Management should be given thyroid hormone, the thyroid hormone replacement. That is thyroxine replacement is the choice of treatment. Remember this. We given the levothyroxine. Levothyroxine should be given 10 to 15 microgram per kg per day for lifelong treatment should be given. Next will be how the follow up of the patient. How the follow up of the patient? Follow up of the patient is mandatory. Every month for 6 months. Follow up of the patient to measurement of the T3, T4, THS every month for 6 months. Then every 2 to 3 months for 2 years. This is the follow up. Now what is the prognosis? What is the prognosis? If the diagnosis of the congenital hypothyroidism is beyond 3 months, then there is a permanent neurological damage should be happened. Thyroid screening should be done. Every thyroid screening. We should do the thyroid screening after birth of the baby. Thyroid screening should be done in 5 to 15 days of age. Remember this. Not after birth. Thyroid screening should be done 5 to 15 days of age. You should remember this one. Next you go for the counseling. Parents counseling is mandatory. Parents counseling is very much important. Remember this. Parents counseling about the natural history of the disease and its outcome. You should remember this one. Natural history of the disease and its outcome is very much important. Regular follow up with respective physician and at least for 2 years. This is all about the congenital hypothyroidism. Thank you very much. Thank you very much for patient hearing.